52 years old. She had insurance through her husband's employer. She was treated for breast cancer, surgery, chemotherapy, radiation, and she survived. She did everything right. She showed up to every appointment, she took the medications, she fought. 2 years later, she and her husband filed for bankruptcy. Her out-of-pocket costs, the portions not covered by insurance, totaled more than $30,000 in the treatment year alone. Deductibles, co-pays, a drug that required prior authorization and was delayed for 6 weeks, so she paid out of pocket to get it faster. Time off work, caregiving expenses, the small things that don't fit into any medical billing category but still cost money. $30,000 while you're already sick. That's not a rounding error. That's financial collapse for most people. This is a term that oncologists started using about a decade ago, though the phenomenon they were describing is much older. Financial toxicity. Toxicity in medicine refers to harmful side effects of treatment. Financial toxicity is the economic harm caused by the cost of medical care, not just bankruptcy, but the ripple effects, skipped medications, delayed procedures, hidden anxiety that degrades health outcomes. The word choice is intentional. Oncologists called it toxicity because they recognized that it had the same clinical relevance as nausea from chemotherapy or immune suppression from a biologic drug. It changes how patients feel. It changes what they do. It changes whether treatment works. And almost nobody warns patients about it. Let's put some numbers on this because the scale is important. A 2019 study published in the American Journal of Public Health, led by Dr. David Himmelstein and colleagues at CUNY, found that 66.5% of personal bankruptcies in the United States have a medical cause, meaning either a medical bill contributed to the bankruptcy or income loss due to illness. 2/3. And critically, 75% of those people had health insurance at the time they got sick. Insurance is protection. It's just not complete protection. And many Americans find out how incomplete it is at the worst possible moment. High deductible health plans, plans where you pay more out of pocket before coverage kicks in, have become the dominant form of employer-sponsored insurance. The average deductible for a single person in an employer plan in 2023 was over $1,700. For family coverage, it was much higher. If you have a serious illness and hit your deductible, you then pay coinsurance, typically 20 to 30% up to your out-of-pocket maximum. For many plans, that maximum is $8,000 or more per person. $8,000 for a family, potentially $16,000 in 1 year while you're sick. If you're a median income American family, $8,000 is about 12% of your take-home pay. And these are the maximum out-of-pocket costs, the costs you encounter even if you do everything your plan says to do. So here's the question. How does this financial pressure actually change what happens to patients medically? Because the answer should change about how we think about healthcare as a whole. Financial toxicity isn't just about bankruptcy. That's the dramatic end of a spectrum that starts much, much earlier, in quieter ways. A skipped refill, a postponed follow-up, a symptom that goes unreported because the patient already knows they can't afford the workup. How financial pressure changes medical behavior is key. The research on this is substantial and consistent. When patients face significant cost sharing, the portion of healthcare costs they pay, they reduce healthcare utilization. They use less of everything: preventative care, specialist visits, medications, emergency visits. This finding goes back to the Rand health insurance experiment in the 1970s and has been replicated repeatedly. The problem is that people don't reduce high value and low value care equally. They reduce everything. Patients facing high cost sharing skip cancer screenings alongside unnecessary tests. They skip maintenance medications alongside procedures they didn't need. The bluntness of cost sharing as a tool is one of its most significant limitations. For patients with chronic diseases, diabetes, heart failure, asthma, medication adherence is not optional. It's the difference between a managed condition and an acute crisis. A 2015 study in the New England Journal of Medicine found that patients who faced higher out-of-pocket costs for cardiac medications after heart attack had significantly higher rates of death and recurrent heart attack compared to patients with lower cost sharing. This is causally meaningful. The financial burden of the medication was associated with people not taking it, and people not taking it died at higher rates. That's not an abstract political concern. That's a patient dying because a copay was too high. Financial toxicity also operates as a psychological burden. That affects clinical outcomes in ways that are harder to measure. A 2021 study in the Journal of Clinical Oncology found that cancer patients who reported financial hardship had worse quality of life scores, higher levels of anxiety and depression, and lower survival rates than patients who did not. The mechanisms are still being studied, but the association is consistent enough that major cancer centers have begun screening for financial distress alongside depression and pain. The National Comprehensive Cancer Network, the organization that sets the clinical guidelines for oncology, now includes financial distress as a domain to assess in its clinical practice guidelines. And yet most of this happens silently. Patients don't tell their doctors they're struggling financially. Physicians don't routinely ask. It's embarrassing. The exam room is not a space where financial vulnerability feels welcome, and the system provides no structural prompt to surface it. So who is most exposed? Financial toxicity is not evenly distributed. Patients who are already economically precarious, patients from communities of color who face both higher medical costs and greater structural barriers to wealth accumulation, and patients with chronic or serious illnesses face disproportionate exposure. A 2023 study in Health Affairs found that Black and Hispanic patients with cancer were significantly more likely to experience catastrophic health expenditures than white patients with the same diagnosis, even after accounting for income. The gap isn't just about money. It's about how the financial architecture of the healthcare system exists with existing inequality. Here's the part that's genuinely difficult to sit with. Financial toxicity is a well-documented clinical phenomenon. Its mechanisms are understood, its consequences are measurable, and yet it remains largely invisible in the design of healthcare policy. We screen for depression, we screen for substance use, we screen for fall risk. We do not routinely screen for the financial distress that is independently associated with worse health outcomes, and in some populations, with death. That is a choice. It doesn't have to be that way. Financial toxicity doesn't announce itself. It accumulates over time. A skipped refill here, a delayed appointment there, a symptom ignored because the last bill hasn't been paid yet. By the time it shows up as a crisis, the quiet decisions that led there are invisible to everyone in the room. What does this mean for patients? The first thing to know is that financial concerns belong in the exam room. Telling your doctor that a medication is too expensive, or that you've been skipping doses, or that you're worried about the cost of a recommended procedure, that's not complaining. That's clinical information they need. A physician who has that information can work with a substitute generic, just a dosing schedule, refer you a patient assistance program, or simply document it so that the team knows what you're dealing with. What doesn't help is rationing medication silently and hoping for the best. Physicians can't address problems they don't know about. If you're facing significant medical costs, most hospitals have financial counselors whose job it is to help patients navigate this. Assistance programs, charity care, payment plans, appeals for financial hardship. This resource exists more often than patients know. Ask your hospital's billing department or the social worker connected to your care team. There are also disease-specific nonprofit organizations, the PEN Foundation, the Health Well Foundation, Patient Advocate Foundation, that provide financial assistance for patients with specific diagnoses who are facing drug costs they can't cover. These programs exist because the problem is real and large. Questions worth asking. Is there a financial counselor I can speak with? Almost all hospitals have that resource, but not all make it visible. Is there a patient assistance program for this drug? Many drug manufacturers offer assistance. Your pharmacist or doctor's office can help identify options. Does this hospital offer charity care or financial hardship assistance? Hospitals that receive federal funding are required to have these policies, but not all advertise them. What are the consequences if I miss a dose or delay this? Your physician should know you're at risk of not doing it and be able to tell you what's most essential versus what has flexibility. In closing, there's something deeply wrong about a system where surviving an illness can financially ruin you, where the people most determined to follow their doctor's orders are undone not by their disease, but by their deductible. The term financial toxicity was coined because physicians needed a way to say, this is a medical problem. It has medical consequences. It belongs in clinical thinking, not just in policy debates. I think that's right, and I think we're just beginning to grapple with what it would actually mean to treat it that way. In the next episode, this is where we're going. We've talked about what patients pay and how those payments can harm them. But there's a related question we haven't touched. How much of what gets ordered and billed actually needed to happen at all? Research suggests that somewhere between 25 and 30% of US healthcare spending, hundreds of billions of dollars, goes to care that provides no benefit to patients and in some cases, many cases, causes harm. Not because of fraud, not because of malice, because of how the system is built. That's the 30% problem, and it's our next episode.